So, picture this. It is 3 o'clock in the morning.
Oh, the classic ICU hour.
Right. The ventilator is just alarming incessantly. You've got a patient whose SpO2 is dropping rapidly, like through the 70s, and the arterial blood gas you just pulled makes absolutely no logical sense.
Yeah, in the clinical world, that's just a standard Tuesday night.
Exactly. But, in your MD anesthesiology viva voce, this is the exact moment the examiner decides your fate. Do you freeze? Or do you completely deconstruct the physiology and, defend your ventilator strategy right there under pressure?
And that's exactly why we do not accept surface-level answers from postgraduate candidates. I mean, when you step into that hall or when you stand at the foot of that ICU bed, you are the ultimate guardian of tissue oxygenation.
Right. So today, for everyone listening, we are not just memorizing textbook definitions. You are stepping into the examiner's mind with us.
We're going to dissect respiratory failure today, not as a static disease, but as a dynamic, evolving physiological collapse. If you can explain the why and the how behind a falling PaO2, you won't just pass, you'll command the room.
I mean, if you can trace that oxygen molecule from the ventilator circuit all the way down to the mitochondria, that's the gold standard. So let's start at the foundation, but let's push past the basic med school stuff.
Absolutely.
Respiratory failure is strictly defined as the inability of the respiratory system to perform adequate intrapulmonary gas exchange. But the numbers attached to this, like a PaO2 of less than 60 millimeters of mercury on room air and a PaO2 greater than 49, they always felt, I don't know, somewhat arbitrary to me when I was a junior resident.
Well, they're anything but arbitrary.
Right. Why it's 60 for the oxygen. Why not 55?
This is exactly where a Viva examiner is going to start probing you. The number 60 is chosen specifically because of the sigmoidal shape of the oxyhemoglobin dissociation curve.
Ah, the cliff.
Exactly, the cliff. At a PO2 of 60, you are standing precisely on the precipice of the steep portion of that curve. So if a patient's PO2 drops from a perfectly normal 100 down to 60, their hemoglobin saturation really only falls from, say, 98% down to about 90%.
So they're still compensating pretty well there.
Right. But once you drop from 60 to 50, you fall off the cliff. The saturation just plummets into the 70s or worse. The examiner wants to see that you understand that 60 is the point of imminent catastrophic failure.
Okay, that makes perfect sense. And what about the PAD2 threshold, the 49 millimeters of mercury?
That's the point at which the carbon dioxide accumulation definitively overcomes the body's normal buffering capacity, assuming, there's no primary metabolic alkalosis driving it.
Right, right.
But more importantly for anesthesia, you must articulate why these thresholds matter to us uniquely. I mean, every single time you induce general anesthesia, you are actively pushing the patient toward respiratory failure.
Because we're abolishing airway tone and depressing the central drive.
Yes, and we are drastically reducing their functional residual capacity, or FRC.
Let's hover on FRC for a second, because the relationship between FRC and closing capacity is just an absolute goldmine for written answers.
It really is.
When we paralyze a patient, the diaphragm relaxes, it gets pushed cephalid by the abdominal content, so the FRC plummets.
Yep.
And if that FRC falls below the closing capacity, the small airways in the dependent regions of the lung they collapse during normal tidal breathing.
They do, and blood continues to flow past those collapsed alveoli, which creates a functional shunt. And that physiological cascade is exactly why the traditional binary classification, just type hypoxemic and type 2 hypercapnic, it's no longer sufficient for a modern exam.
Right, the examiners want more now.
They expect you to utilize the expanded classification system. You absolutely have to bring type 3 and type 5 into your written essays and your Viva discussions. It proves you have a comprehensive understanding of perioperative medicine.
Okay, so let's map out that expanded system for the listener. We have a patient crashing over that oxygenation cliff. If it's a pure oxygenation failure, the classic type I, we're defining it by a PO2 below 60 with a normal or even low PaO2.
Correct. So type I is primarily a parenchymal issue.
The lung tissue itself.
Exactly. The alveoli, the interstitium, the capillary interface, that's what's diseased. And this is acute and life-threatening because, well, the brain and the heart simply cannot survive prolonged hypoxemia.
Right. And then type 2, conversely, is hypercapnic respiratory failure. So that's ventilatory insufficiency.
Yes. The PaO2 is still below 60, But the hallmark here is a PaO2 greater than 45 or 50, accompanied by a respiratory acidosis. This isn't the lung tissue. This is a failure of the pump.
So the central nervous system drive, the neuromuscular junction, the chest wall mechanics.
Precisely.
But then we get to type 3, which is honestly arguably our specific domain as anesthesiologists, the perioperative or atelectatic respiratory failure. We're essentially talking about the iatrogenic consequences of our interventions, right, and surgical trauma.
Indeed we are. Type 3 relates specifically to postoperative atelectasis and altered lung mechanics. I mean, think about it. When a patient undergoes major abdominal surgery, they experience significant pain.
Or they splint their diaphragm?
Exactly. They simply will not take deep breaths. Combine that with the residual effects of volatile anesthetics, neuromuscular blockade, opioid-induced respiratory depression.
And just being supine.
Right, supine positioning. Their FRC just collapses. Secretions pool. The airways close. Examiners want to see you classify this distinctly because the management is entirely different from a classic type I pneumonia.
Yeah, you're looking at early mobilization, regional anesthesia for pain control, incentive spirometry, maybe some CPAP, not antibiotics and proning.
Exactly.
Okay, what about type 5? Because I feel like this is the one that really trips candidates up. Shock-related respiratory failure.
That's a tricky one.
If a patient is in profound hemorrhagic or cardiogenic shock, their primary problem is hemodynamic collapse. So why on earth do we classify this under a respiratory failure umbrella?
That is a phenomenal analytical question. Let's look at the hemodynamics of the respiratory muscles themselves.
Okay.
In a healthy resting individual, the work of breathing consumes merely 2 to 3% of the total cardiac output. It's negligible.
Right.
But in a state of profound shock, where there is systemic hypoperfusion and severe metabolic acidosis, the respiratory rate skyrockets. The body is desperately attempting to blow off CO2 to compensate for the lactic acidosis.
So the diaphragm and intercostal muscles are just working furiously.
Furiously. And in this state, the work of breathing can consume up to 50% of total oxygen delivery.
Wait, 50% just for breathing?
Yes.
So the respiratory muscles are actively stealing blood flow from the splanchnic bed, the kidneys, the brain, just to keep the chest wall moving.
Exactly. The cardiovascular system is already failing, and it simply cannot supply enough oxygen to these vigorously working muscles. Eventually, those muscles experience ischemia.
They fatigue.
They fatigue, and you get sudden respiratory arrest. When we intubate a patient in severe shock, we are not necessarily doing it just because their PO2 is low. We're doing it to take over the work of breathing.
Wow. So by paralyzing and mechanically ventilating them, we instantly liberate that massive percentage of cardiac output and give it back to the vital organs.
Precisely. If you explain that hemodynamic redistribution in your exam, you prove that you understand the integrated pathophysiology of a critically ill patient.
Man, that is the kind of insight that turns a failing grade into a distinction. All right, so we know the broad classifications. Let's drill down into the microscopic breakdown.
Let's do it.
If the respiratory muscles are intact, but oxygenation is still failing, what is breaking down within the lung itself? We need to thoroughly dissect the 5 mechanisms of hypoxemia. This is exam gold.
It's non-negotiable for the exam. You have to be able to list, define, and physiologically explain all 5. The first, and overwhelmingly the most common, is ventilation-perfusion mismatch, or VQ mismatch. This occurs when alveoli are underventilated relative to their perfusion. So you get a low VQ ratio.
And to really understand VQ mismatch at a postgraduate level, we have to bring up West's zones of the lung, right?
Absolutely.
Because gravity dictates both ventilation and perfusion, so they're never perfectly matched, even in a totally healthy person. Perfusion is heavily gravity dependent, so it pools in the lung bases.
Yes, and ventilation also increases at the bases, but just not to the same degree as perfusion.
Right, so the base of the lung naturally has a lower VQ ratio than the apex.
Precisely. And any pathological state that exacerbates this normal inequality causes hypoxemia. I mean, take it asthma exacerbation. Intense bronchoconstriction limits ventilation to certain lung units, but blood continues to flow past them.
So the blood leaving those units has a super low oxygen content.
Right. And when that mixes with the well-oxygenated blood from the healthy units, the overall arterial PO2 drops.
But the body has a defense mechanism against this, doesn't it? Hypoxic pulmonary vasoconstriction, or HPV.
Yes, and you must mention HPV in your answers. It's critical. When an alveolosis becomes hypoxic, the mitochondria in the adjacent pulmonary artery smooth muscle cells actually sense that drop in oxygen.
And that triggers a cascade.
It does. It changes potassium channel activity, leading to cellular depolarization, calcium influx, and intense local vasoconstriction. The body intelligently shunts blood away from the poorly ventilated alveolus toward the better ventilated areas.
Trying to fix its own VQ mismatch.
Exactly.
But what happens when that mismatch is so severe that it just completely eliminates ventilation? That brings us to mechanism number 2. Shunt, specifically right to left shunt, where the VQ ratio equals absolute 0.
A shunt occurs when mixed venous blood from the right side of the heart passes to the left side without ever participating in gas exchange.
So it completely bypasses the system.
Right. This can be intracardiac, like a VSD or tetralogy of Fallot, or more commonly for us, it could be intrapulmonary.
Like when alveoli are totally filled with fluid in ARDS or completely collapsed in severe atelectasis. Let me push you on a critical clinical scenario regarding shunt, because this comes up a lot. If a true shunt means blood is completely bypassing ventilated alveoli, then walking up to the ventilator at 3 a.m. and cranking the FiO2 up to 100%. That's not just unhelpful, right? It's potentially causing oxygen toxicity without actually fixing the profound hypoxia.
That right there is the ultimate test of a candidate's understanding of oxygen transport.
What's the physiological reason for that failure to respond?
Remember the oxygen delivery equation. The vast majority of oxygen is bound to hemoglobin. Only a tiny, tiny fraction is dissolved in the plasma. In a severe shunt, the blood perfusing the collapsed alveoli leaves completely deoxygenated.
If there's no air there.
Right. Meanwhile, the blood perfusing the healthy alveoli is already 100% saturated, even at room air or moderate FiO2. You physically cannot put more than 4 molecules of oxygen on a single hemoglobin molecule.
Right, it's maxed out.
So by increasing the FiO2 to 100%, you are only slightly increasing the dissolved oxygen in the plasma of those healthy units. When that tiny amount of extra dissolved oxygen mixes with the massive volume of completely deoxygenated shunted blood.
It does nothing. The PO2 barely moves.
Exactly. Oxygen is essentially useless for a true shunt.
So what's the actual physiological intervention then?
You must apply positive end expiratory pressure, or PEEP. PEEP physically splints the collapsed airways open. It forces alveolar fluid back into the interstitium and recruits those collapsed units back into the functional lung volume.
Converting a 0 VQ ratio back into a viable ventilated unit.
Precisely.
Okay, so we have VQ, mismatch, and shunt. What is the third mechanism of hypoxemia?
Diffusion impairment. This relates directly to Fick's law of diffusion, which states that the rate of gas transfer is directly proportional to the surface area and pressure gradient and inversely proportional to the thickness of the membrane.
Right, so conditions like pulmonary fibrosis or interstitial lung disease where the membrane gets severely thickened with scar tissue.
Yes.
And the classic Viva trap here involves exercise, doesn't it? Like a patient with early pulmonary fibrosis might have a normal PO2 sitting on the exam table, but the moment they walk down the hall, they become profoundly desaturated.
Exactly. And you need to explain the timing. At rest, a red blood cell spends about 0.75 seconds traversing the pulmonary capillary. Even with a thickened membrane, oxygen usually has enough time to equilibrate.
But during exercise, cardiac output massively increases.
Right, which drives the blood through the capillary much faster. The transit time might drop to 0.25 seconds. The oxygen simply cannot diffuse across that thick fibrotic barrier fast enough before the red blood cell is just swept away into the systemic circulation.
That makes perfect sense. Okay, fourth mechanism.
Hypoventilation. This is a global reduction in minute ventilation. We'll explore this deeply when we look at the alveolar gas equation. But essentially, if you aren't bringing fresh air into the lungs, the partial pressure of carbon dioxide in the alveolus rises steadily as metabolism continues.
And because the total pressure in the alveolus is fixed by atmospheric pressure, that rising CO2 physically displaces the oxygen molecules.
Leading to hypoxemia.
Yes.
Got it.
And the fifth and final mechanism.
Reduced inspired oxygen tension, or a low FiO2. The textbook example is ascending to high altitude, where the barometric pressure drops, thus dropping the partial pressure of oxygen.
But in the realm of anesthesia, we need to talk about equipment, right?
Absolutely. You must mention the risk of a hypoxic gas mixture due to a pipeline crossover, an empty oxygen cylinder, or a flow meter failure.
Great. So let's apply these mechanisms to real clinical pathologies. How does the examiner want us to categorize the causes of type I and type 2 failure?
For type I, the parenchymal failure, you're looking at diseases that fill or collapse the alveoli. Pneumonia fills them with pus and inflammatory exudate. Cardiogenic pulmonary edema fills them with transsudative fluid due to elevated hydrostatic pressure from a failing left ventricle.
And ARDS fills them with protein-rich fluid because of overwhelming capillary leak. Let's talk about pulmonary embolism, because this is just a fascinating pathological evolution. If the examiner gives you a scenario, day 3, post-op from major orthopedic surgery, sudden hypoxemia and tachycardia, we suspect a PE.
Classic.
But wait, a PE physically blocks blood flow to a segment of the lung that creates ventilation without perfusion, which is alveolar dead space, or an infinitely high VQ ratio. And dead space impairs CO2 clearance, leading to hypercapnia. So why is the hallmark of an acute PE profound hypoxemia?
That is the exact physiological paradox the examiner wants you to solve out loud. You're correct. The initial insult is pure dead space. But within minutes, a complex secondary cascade begins.
The platelets.
Yes, the platelets adhering to the embolus degranulate. They release potent vasoactive and bronchoconstrictive mediators like serotonin and thromboxane A2. This causes intense localized bronchospasm in the surrounding uninfarcted lung tissue.
Wow. And the lack of pulmonary blood flow starves the type 2 pneumocytes too, right?
Exactly. They cease producing surfactant.
And without surfactant, alveolar surface tension skyrockets and the alveoli collapse.
Precisely. So now you have severe atelectasis and bronchoconstriction in the lung units surrounding the embolus. As blood flow is diverted away from the blocked artery, it's forced to perfuse these now collapsed, unventilated alveoli.
So the initial high VQ dead space has rapidly evolved into a low VQ functional shunt.
Yes. That secondary shunting is the primary driver of the severe refractory hypoxemia seen in a massive PE.
That is a brilliant breakdown. Now let's look at the pump failure, the causes of type 2 respiratory failure.
For your exam structure, always break type 2 down anatomically. Start at the brain and work your way down.
Okay, so first, CNS depression.
Yes. This includes drug overdoses like opioids, benzodiazepines, or barbiturates that suppress the medullary respiratory centers. It also includes brainstem strokes or profound hypothyroidism leading to myxedema.
Second would be the wiring, the neuromuscular disorders.
Right. Conditions like Guillain-Barré syndrome, myasthenia gravis, ALS, or a high cervical cord lesion. Take Guillain-Barré, for example. You have an acute ascending demyelinating polyneuropathy.
As the demyelination reaches the phrenic nerves and intercostal nerves, the motor units just fail.
They do. The patient's vital capacity progressively drops. They physically cannot generate the negative intrathoracic pressure required to pull air into the lungs. Alveolar hypoventilation ensues, and CO2 begins to climb.
Third, the physical structure itself, chest wall and pleural disorders.
Yes. Severe kyphoscoliosis mechanically restricts expansion. Morbid obesity causes massive chest wall loading, which drastically reduces compliance. Or a massive pleural effusion or tension pneumothorax that physically compresses the lung tissue.
And finally, airway obstruction.
COPD is the most common chronic cause here, but severe acute asthma exacerbations can also lead to type 2 failure when the patient finally fatigues after hours of breathing against immense airway resistance.
Okay, we know the definitions, the classifications, the mechanisms, and the causes. But how do we actually prove which mechanism is at play in the clinical setting? We need to transition to arterial blood gas interpretation, because reading an ABG in an OSCE under a strict time limit is terrifying.
It can be. The math gets jumbled, the numbers blur together.
We need a rigid, bulletproof system.
You must approach every ABG like a mathematical proof.
Yeah.
Step 1, look at the PO2. Is the patient hypoxemic? Step 2, look at the PO2. Is it low, normal, or elevated? This immediately differentiates type I from type 2.
Step 3, look at the pH, acidemia, alkalemia, or normal.
Exactly. And step 4, assess compensation. This is where you differentiate an acute respiratory acidosis from a chronic one.
Let's demystify the math of compensation. How much should the bicarbonate rise in response to a climbing CO2?
You must memorize the 1 for 10 and 4 for 10 rules. In acute respiratory acidosis, say an acute opioid overdose, the kidneys haven't had time to compensate. The initial buffering is purely cellular.
So for every 10 millimeter of mercury rise in PaCO2 above the normal baseline of 40, the serum bicarbonate will passively increase by 1 milliequivalent per liter.
Correct. But if it's a chronic condition like severe COPD,
the kidneys have had days or weeks to adapt.
Right. They upregulate the retention of bicarbonate and the excretion of hydrogen ions. In this state, for every 10 millimeter of mercury rise in PaCO2 above 40, the bicarbonate will increase by 4 milliequivalents per liter.
Okay, so if a patient has a baseline PaCO2 of 70, which is 30 above normal, their bicarbonate should be elevated by roughly 12, putting them at a baseline bicarb of around 36.
Exactly. And if their bicarb is 36 and their pH is near normal, this is a chronic compensated state. You absolutely must not rapidly ventilate their CO2 down to 40, or you'll cause a profound, life-threatening metabolic alkalosis.
That's such a crucial point. But the absolute holy grail of ABG interpretation in an exam setting is the alveolar arterial, or A gradient. If you fail to calculate this in a Viva,
You will likely fail the station, period.
let's focus heavily on this. I've always struggled with the abstract nature of the alveolar gas equation. It's just a string of letters and numbers. Can we conceptualize this? Like, let's think of the alveolus not as a balloon, but as a rigid box with a fixed volume.
I like that. That's an excellent framework.
At a given atmospheric pressure at sea level, that box can only hold a certain absolute number of gas molecules.
Right. The pressure inside that rigid box is determined by atmospheric pressure. Now, the majority of the molecules in the box are nitrogen, which is inert and doesn't participate in gas exchange. Water vapor takes up a fixed amount of pressure, too.
So what is left over is the space available for just oxygen and carbon dioxide.
Precisely. So if a patient develops Guillain-Barré and stops ventilating, the metabolic production of CO2 continues. CO2 molecules begin flooding into that rigid box. Because the box cannot expand and the pressure must remain constant, those accumulating CO2 molecules physically displace and push the oxygen molecules out of the alveolus.
Wow, okay, so the partial pressure of oxygen in the alveolus capital PaO2 must fall as the PaCO2 rises.
That physical displacement is represented mathematically by the alveolar gas equation. Listeners, write this down carefully. PaO2 equals the FiO2, multiplied by the atmospheric pressure minus the vapor pressure of water.
Okay.
From that entire product, you subtract the pKO2 divided by the respiratory quotient, which is typically 0.8.
Let's do the math live for a specific clinical case so they can hear it in action. Patient is on room air, which is 21% or 0.21 FiO2. We're at sea level, so atmospheric pressure of 760. Water vapor is 47.
So 760 minus 47 is 713. Multiply that by 0.21, and you get approximately 150.
150. This is the partial pressure of oxygen in the conducting airways before gas exchange begins.
Correct. Now we must subtract the alveolar CO2. Since alveolar CO2 rapidly equilibrates with arterial CO2, we use the pKO2 from our blood gas, divided by 0.8.
Okay, let's say our exam candidate is handed an ABG. The patient is breathing room air, their PO2 is 50, and their pKO2 is 70. The immediate reaction of a panicked student is to look at the low PO2 and say, oh, the patient has lung disease, maybe pneumonia.
Which is immediately incorrect. Let's run your numbers through the rigid box. We start with 150, then we subtract the result of 70 divided by 0.8.
70 divided by 0.8 is 87.5.
Right, so 150 minus 87.5 leaves us with the PaO2, the oxygen actually sitting in the alveolus of 62.5 millimeters of mercury.
So the box only contains 62.5 millimeters of mercury of oxygen purely because the CO2 took up all the space?
Exactly. Now we calculate the gradient. The alveolar oxygen is 62.5. The ABG tells us the arterial oxygen is 50. We subtract the two.
62.5 minus 50 is a gradient of 12.5.
And an A gradient of 12.5 on room air is entirely normal. A normal gradient generally falls between 5 and 15, increasing slightly with age. What this normal gradient definitively proves is that there is absolutely no barrier to diffusion.
There is no shunt. There is no VQ mismatch.
The lung parenchyma is pristine. The oxygen transferred perfectly from the alveolus to the blood. The only reason the arterial oxygen is low is because the alveolar oxygen was displaced by hypoventilation.
That is the ultimate Viva trap right there. If you see a PaO2 of 50 and a pKO2 of 70, you must calculate the A gradient before you blurt out a diagnosis. If it's normal, the lungs are fine. You need to investigate the CNS, the spinal cord, or the neuromuscular junction.
Exactly.
And if you calculate it and the gradient is widened, say, 40 or 50, then you know you have concurrent parenchymal disease. That single calculation is the difference between passing and failing.
The mathematics dictates the clinical management. Now let's move away from the paper and look at the patient in the bed. We need to discuss clinical features and diagnosis.
We're always taught to look for cyanosis as the cardinal sign of hypoxia. But is it actually reliable?
It is notoriously unreliable, depending on its critical error. Central cyanosis, the bluish discoloration of the tongue and mucous membranes, does not depend on the percentage of oxygen saturation.
What does it depend on?
It depends on the absolute concentration of deoxygenated hemoglobin in the capillaries. Specifically, you need about 5 grams per deciliter of deoxygenated hemoglobin to visually perceive cyanosis.
So if a patient has severe anemia, let's say they had a massive intraoperative hemorrhage and their total hemoglobin is now only 6.
If their total hemoglobin is 6, they could have an SpO2 of 70%, meaning they are profoundly hypoxic and suffering cellular death, but they will only have roughly 1.8 grams of deoxygenated hemoglobin.
So they won't look blue at all.
They will look pale, perhaps ashen, but they will never turn cyanotic because they simply do not possess enough hemoglobin to cross that 5-gram visual threshold. Conversely, a patient with severe polycythemia and a hemoglobin of 20 might look completely blue while maintaining a perfectly adequate oxygen delivery.
Wow. So you must rely on your ABG and your clinical signs of sympathetic activation, tachycardia, tachypnea, agitation, confusion.
Absolutely.
What about the signs of hypercapnia?
Carbon dioxide is a potent peripheral vasodilator and a CNS depressant. Clinically, you'll see warm, flushed extremities, a bounding pulse, tremors, asterixis or flapping tremors, headache, and progressively deepening drowsiness or coma.
The vasodilation aspect is a massive trap in neuroanesthesia, right?
It is paramount. CO2 doesn't just dilate peripheral vessels. It is the primary regulator of cerebral blood flow. For every 1 millimeter of mercury rise in PaCO2, cerebral blood flow increases by approximately 1 to 2 milliliters per 100 grams of brain tissue per minute.
So if you have a patient with a traumatic brain injury who goes into type 2 respiratory failure,
That rising CO2 will massively engorge the cerebral vasculature. In a fixed cranial vault, that increased blood volume causes a spike in intracranial pressure, potentially leading to brain herniation and death. This is why strict PaCO2 control, often targeting low normal levels, is mandatory in neuroanesthesia.
okay, aside from the ABG, what other investigations are examiners looking for?
The chest X-ray is fundamental, primarily to differentiate the causes of acute pulmonary edema. If the X-ray shows cardiomegaly, curly B lines indicating interstitial fluid and pleural effusions, you're likely dealing with cardiogenic failure.
But if the heart size is normal and you see diffuse bilateral patchy alveolar infiltrates, the classic whiteout lung, you suspect non-cardiogenic edema, specifically ARDS. And what role do pulmonary function tests play? Because we don't usually do them at 3 a.m.
True, we don't. But for chronic causes of respiratory failure, KFTs are vital for differentiating obstructive from restrictive diseases. In obstructive disease like COPD, the hallmark is a low FEV1-FVC ratio, typically less than 0.7.
And in restrictive disease like pulmonary fibrosis.
The total lung capacity and FVC are low, but the FEV1-FVC ratio remains normal or even high because the elastic recoil is preserved or increased. You should be prepared to draw the flow volume loops on the whiteboard too.
Right, an obstructive loop will show a classic scooped out or coved expiratory phase due to dynamic airway collapse.
Exactly. You must be able to draw that.
All right, we have classified it, mapped the pathophysiology, calculated the gradient, and reviewed the imaging. Now we must treat the patient. Management is absolutely essential. Where do we begin?
You never ever skip the basics in an exam. You start with the rigid ABC framework. Airway, assess patency. If the patient has an altered sensorium and absent gag reflex or is unable to clear copious secretions, you secure the airway immediately with endotracheal intubation.
Breathing. Optimize oxygenation and assess the need for mechanical ventilatory support.
Right, and circulation. Establish large-bore IV access, commence fluid resuscitation if indicated, and manage shock with vasopressors or inotropes to ensure that once you oxygenate the blood, it actually gets to the tissues.
Let's talk about oxygen therapy under breathing. The junior reflex is often to just crank the flow meter up to 15 liters through a non-rebreather mask for everyone who looks breathless, but that's dangerous, isn't it?
Saying that in Aviva will immediately cost you marks. Oxygen is a drug. It has specific indications, toxicities, and targets. In a patient with no chronic lung disease presenting with acute hypoxemia, your target SO2 is generally 92 to 98%.
But in a patient with chronic COPD who is a known CO2 retainer, your target is strictly 88 to 92%. We need to explain exactly why oxygen can kill a COPD retainer. The old dogma was simply that their brain is so used to high CO2 that their respiratory drive switches entirely to a hypoxic drive. And if you give them oxygen, they just stop breathing. But modern physiology tells us it's much more complex than that.
The hypoxic drive theory is a gross oversimplification. Giving high-flow oxygen to a COPD patient exacerbates hypercapnia through two distinct physiological mechanisms that you must articulate. The first is the Haldane effect.
Let's break that down.
Deoxygenated hemoglobin has a high affinity for binding carbon dioxide.
Mm.
When you flood the blood with oxygen, the hemoglobin becomes fully saturated with oxygen. This oxygenated hemoglobin physically changes its conformation and drastically lowers its affinity for CO2.
Forcing massive amounts of CO2 to be dumped from the red blood cells back into the plasma, sharply spiking the PEEK-O2.
Exactly, that's the chemical mechanism.
And the hemodynamic mechanism.
The second mechanism involves the reversal of hypoxic pulmonary vasoconstriction. Remember, the COPD patient has chronic, poorly ventilated emphysematous bullae. Their body has intelligently constricted the blood vessels around those useless bullae to shunt blood to better areas.
Right, so when you give them high concentrations of inspired oxygen, that oxygen diffuses into those poorly ventilated spaces.
Yes, the local hypoxia is temporarily reversed, and those constricted pulmonary vessels suddenly dilate. Now, massive amounts of blood flow are rushing to lung units that have terrible ventilation mechanics.
So you've massively worsened the global VQ mismatch and vastly increased the alveolar dead space.
Leading to a further dangerous climb in PACO2.
That is a masterclass explanation. Now, what devices are we using to deliver oxygen precisely?
Venturi masks are excellent for these patients because they utilize the Bernoulli principle to entrain room air at a fixed ratio, delivering a highly controlled, precise FiO2, say, exactly 24% or 28%.
And we also rely heavily on high-flow nasal cannula, HFNC.
Yes. HFNC provides heated, humidified oxygen at flow rates up to 60 liters per minute, which flushes out the anatomic dead space in the nasopharynx. Importantly, the high flow generates a mild CPAP effect of roughly 3 to 5 centimeters of water, which helps splint the upper airways open and recruit alveoli.
But if HFNC isn't enough, we move up the escalation ladder to non-invasive ventilation, NIV.
Right. NIV, specifically BiPAP, which provides both inspiratory and expiratory positive airway pressure, is strongly indicated for two main pathologies. First, acute exacerbations of COPD complicated by hypercapnic acidosis, generally a pH between 7.25 and 7.35.
And second, acute cardiogenic pulmonary edema.
Yes, where the positive pressure literally pushes the hydrostatic fluid back out of the alveoli and decreases left ventricular preload.
The advantages of NIV are obvious. You avoid the morbidity of an endotracheal tube, ventilator-associated pneumonia, and the need for deep sedation. But when must we say no to NIV and proceed straight to intubation?
Absolute contraindications include a patient in a coma or with an altered sensorium who cannot protect their airway, hemodynamic instability or severe shock, facial trauma or burns precluding a mask seal, and a high risk of aspiration, such as active hemonesis.
So if those are present, or if the patient's pH drops below 7.25 despite NIV, you must proceed to invasive mechanical ventilation.
You have no other choice.
Okay, the patient is intubated, they have severe ARDS. What are the high-yield, examiner-approved ventilator settings?
The examiner wants to hear you systematically describe lung protective ventilation, specifically based on the ARDSNet protocol. You must drill these specific parameters into your memory. First, you utilized low tidal volumes, specifically targeting 6 milliliters per kilogram of predicted body weight, not actual body weight.
Let's emphasize that. Why predicted body weight?
Because your lungs do not grow larger when you gain adipose tissue. A 150-kilogram man of average height has the exact same lung capacity as a 70-kilogram man of the same height.
Right, so if you calculate 6 millokilograms based on actual body weight for the obese patient, you'll deliver a massive destructive tidal volume.
Exactly. We strictly use low tidal volumes to prevent volutrauma, the physical overdistension and tearing of the fragile alveolar epithelium.
The second parameter is pressure.
We must maintain a plateau pressure, the static pressure in the alveoli at the end of inspiration, of less than 30 centimeters of water. This prevents barotrauma, which can cause macroscopic alveolar rupture, leading to pneumothorax or pneumomediastinum.
And the third parameter is PEEP. We've mentioned it before, but we need to discuss the hemodynamic trade-offs. We crank up the PEEP to open the lung, recruit collapsed alveoli, and overcome the right-to-left shunt. But the heart is sitting right in the middle of those lungs. It's not a free lunch.
Far from it. This is a critical concept that bridges pulmonary physiology with cardiovascular intensive care. PEEP is inherently unnatural. Humans breathe via negative intrathoracic pressure, which sucks blood back into the right atrium.
When we apply significant PEEP, we're transmitting positive pressure throughout the thoracic cavity.
Right, and this positive pressure compresses the superior and inferior vena cava, drastically impairing venous return, or preload, to the right heart.
And if the right heart doesn't fill, it can't pump.
Furthermore, high PEEP compresses the delicate pulmonary capillaries running between the distended alveoli. This increases pulmonary vascular resistance, which is essentially an increase in right ventricular afterload.
So the right ventricle is receiving less blood, and it has to pump harder to push it through the lungs.
Consequently, right ventricular stroke volume drops, which means left ventricular filling drops, causing a severe reduction in cardiac output and systemic blood pressure.
So let's tie this back to the ultimate goal, tissue oxygenation. What does this mean for the patient mathematically?
We return to the oxygen delivery equation. Oxygen delivery, DO2, is the product of cardiac output multiplied by arterial oxygen content. The oxygen content is mostly determined by hemoglobin concentration and saturation.
So if you increase the PEEP from 10 to 18, you might recruit alveoli, resolve the shunt, and see the PO2 and saturation on the monitor rise beautifully.
But if that high PEEP simultaneously drops your cardiac output by 40% because of impaired venous return, the total product of the equation, the actual molecules of oxygen arriving at the brain and kidneys, might plummet.
You literally sacrificed cardiac output for a prettier blood gas, and the patient still dies of cellular hypoxia.
Exactly. The art of mechanical ventilation is titrating PEEP to find the optimal point where alveolar recruitment is maximized without severely compromising cardiac output. That complex hemodynamic interplay is exactly what a senior examiner is waiting to hear.
This transitions perfectly into Part H complications and ICU care. We've touched on barotrauma and volley trauma under the umbrella of ventilator-induced lung injury, or VILI, but what are the other components?
Aside from barotrauma pressure damage and volutrauma volume tearing, you must define atalic trauma. This is the shear stress injury caused by the repetitive opening and closing of unstable, fluid-heavy alveoli with every single breath.
It's like constantly bending a paperclip until it snaps.
Exactly. Adequate PEEP prevents this by keeping the alveoli splinted open throughout the respiratory cycle. Finally, there is biotrauma.
Biotrauma is fascinating. It's where physical physics turns into systemic biology.
Precisely. It is mechanotransduction. The physical stretching and tearing of the alveolar epithelium trigger a massive release of pro-inflammatory cytokines like interleukin-6 and TNF-alpha into the systemic circulation.
So you're literally mechanically generating a state of systemic inflammatory response syndrome, or SIRS.
The lung trauma becomes a systemic sepsis mimic, leading to multi-organ dysfunction syndrome. Other complications include ventilator-associated pneumonia, which carries a high mortality, and oxygen toxicity, where prolonged exposure to 100% IO2 generates reactive oxygen species that destroy the pulmonary endothelium.
So how are we monitoring these intubated patients to prevent this?
Meticulous continuous monitoring. Arterial lines are mandatory for continuous blood pressure assessment, especially given the hemodynamic effects of PEEP we just discussed, and for frequent ADG sampling. We also rely heavily on continuous capnography, or ETCO2.
Because a sudden, precipitous drop in ETCO2 could immediately indicate a massive pulmonary embolism or a disconnect in the ventilator circuit.
Exactly. While a gradual rise indicates increasing dead space or worsening hypoventilation.
Let's look at the endgame, getting them off the ventilator. Weaning. You assess readiness with spontaneous breathing trials, but examiners love to test the cardiovascular impact of weaning, don't they? It's kind of the inverse of the PEEP problem.
It is the exact inverse. We call it weaning-induced pulmonary edema. Think about the hemodynamics. A patient's been on positive pressure ventilation for a week. The positive pressure has been suppressing their venous return and artificially assisting their left ventricle by reducing its transmural pressure gradient, essentially reducing LV afterload.
Now we suddenly turn off the positive pressure and make them breathe on their own through an endotracheal tube, which acts like a narrow straw.
Right. To pull air through that narrow resistance, the patient must generate a massive negative intrathoracic pressure. This sudden violent vacuum effect has two catastrophic consequences.
Oh, wow. First, it sucks a massive volume of venous blood back into the right heart, flooding the pulmonary circulation.
Exactly. Second, the extreme negative pressure surrounding the heart vastly increases the afterload on the left ventricle. It is like the left ventricle is trying to pump blood out of a black hole.
The sudden volume overload combined with immense afterload can cause acute left ventricular failure.
Yes. The fluid backs up, and they develop flash pulmonary edema. They aren't failing to breathe. Their heart is failing from the sudden work of breathing.
That is an incredible physiological narrative. Let's pull everything together into part one, exam integration. We need to build a mental comparison table that our listeners can write down for type I versus type 2.
Listeners, visualize a table with type I in the first column and type 2 in the second. Row 1, pathophysiology. Type I is fundamentally a VQ mismatch, or a right-to-left shunt. Type 2 is fundamentally alveolar hypoventilation.
Row 2, ABG findings. Type I shows a PaO2 less than 60 with a normal or low PaCO2. Type 2 shows a PaO2 less than 60 but with a PaCO2 greater than 45 and respiratory acidosis.
Row 3 causes. Type O is caused by alveolar filling or collapse, ARDS, pneumonia, pulmonary edema. Type 2 is caused by pump failure, COPD, neuromuscular blockade, opioid overdose.
And row 4, management focus. Type I requires PEEP to recruit alveoli and carefully titrated FiO2. Type 2 requires ventilatory support, either NIV or invasive ventilation, to physically increase minute ventilation and clear the CO2.
Exactly.
What are the specific Viva traps that trip up candidates?
The most common mistakes include failing to calculate the A gradient before diagnosing a mixed ABG, confusing the causes of dead space versus shunt, and, as we discussed, believing that administering 100% oxygen will cure a severe true shunt. Examiners will also explicitly ask you to define permissive hypercapnia in the context of ARDS.
How should they phrase that definition to secure full marks?
The examiner-approved answer is, permissive hypocapnia is an intentional lung protective strategy where elevated PaCO2 is tolerated in order to minimize tidal volumes and keep plateau pressures below 30 centimeters of water. The goal is to prevent ventilator-induced lung injury, provided that the arterial pH does not fall below 7.20 and there are no contraindications such as elevated intracranial pressure.
Boom. Perfect. And regarding visual aids, in a written exam, a good diagram is worth an entire page of text.
You must be able to confidently draw 3 diagrams. First, the VQ mismatch spectrum. Draw a horizontal line. On the far left, show dead space where VQ equals infinity because perfusion is 0. In the middle, show normal matching where VQ is roughly 0.8. On the far right, show shunt where VQ equals 0 because ventilation is 0.
Second, draw the oxygen dissociation curve, explicitly detailing the Bohr effect and the metabolic factors like temperature, 2,3-DPZ, and pH that shift it left or right.
And third, provide a clean branching flow chart for your ABG interpretation.
Let's do a rapid-fire summary of the absolute high-yield take-homes.
Number 1, define failure rigorously. PaO2 under 60, PaCO2 over 49. Know why those numbers matter on the dissociation curve. Number 2, classify completely. Use types A through 4, particularly emphasizing the FRC collapse in perioperative type 3 and the massive hemodynamic theft by the respiratory muscles in shock-related type 4.
Number 3, understand the 5 mechanisms of hypoxemia, specifically how PE evolves from dead space to shunt due to lack of surfactant and bronchoconstriction. Number 4, always calculate the A gradient using the rigid box of the alveolar gas equation to isolate parenchymal disease from hypoventilation.
Number 5, execute lung protective ventilation. 6 millikilogram predicted body weight, plateau pressure under 30, and titrated PEEP. And number 6, master the hemodynamics. Articulate how PEEP drops cardiac output and how sudden negative pressure during weaning triggers acute left ventricular failure.
If a candidate reaches the end of a 20-mark written essay on this topic, they need a strong closing statement. Could you dictate a model conclusion paragraph?
Absolutely. In conclusion, respiratory failure represents a critical collapse of oxygenation, ventilation, or both, fundamentally disrupting tissue oxygen delivery. Management mandates a rapid, systematic approach centered on robust ABG interpretation to identify the underlying physiological mechanism, whether it be intrapulmonary shunt, severe VQ mismatch, or alveolar hypoventilation. Definitive therapy requires a delicate balancing act, restoring adequate gas exchange via targeted oxygenation and lung-protective mechanical ventilation, while vigilantly mitigating the severe hemodynamic compromises and biotrauma inherent to positive pressure support.
That is authoritative. If you write that, you have proved you belong in the specialty.
Before we conclude, I want to leave you with one final advanced physiological concept to ponder. We have spent this entire session rigorously dissecting macrocirculatory parameters. We have balanced PaO2, cardiac output, and oxygen delivery equations. But remember, the ultimate frontier in modern intensive care is the microcirculation.
Oh, right, the capillaries.
Yes. You can perfectly recruit the lungs. You can achieve a flawless ABG. You can utilize inotropes to generate a completely normal cardiac output and blood pressure. But in severe sepsis, the microcirculation fails. Endothelial swelling and microthrombi physically shunt blood flow past the capillary beds directly into the venules, bypassing the mitochondria completely.
So the oxygen is right there, but it can't cross.
Exactly. Furthermore, the mitochondria themselves become poisoned and unable to utilize whatever oxygen does arrive, a state known as cytopathic dysoxia. The cells starve in a sea of plenty. The next time you are standing at the bedside of a septic patient staring at a perfect ABG and a normal blood pressure, but the lactate continues to rise and the patient is still dying, ask yourself, what is happening at the microscopic mitochondrial level?
And realizing how much we still have to control at that microscopic level is exactly what keeps this specialty so humbling and so fascinating. Thank you for an incredibly rigorous, exhausting, but ultimately exam-crushing masterclass.
It was my pleasure.
And to you listening, remember that while this deep dive equips you to dominate your exams, the true final goal is saving the physiological life of the patient in that ICU bed. The diagnostic landscape might be muddy, but your physiological reasoning is now crystal clear. Keep studying the mechanisms, keep questioning the numbers, and keep diving deep.